Okay, this is going to be the lecture over not only 3D planning, but also IMRT planning. We're not going to delve too much into the specifics of each other than just to give you an idea as to what's involved. You're not going on to create these kinds of plans, so it's not critical that you know a lot of the specific details here, but it is something that you need to know when it comes to what did these things look like on the machine and what sort of characteristics are involved with each. So I want to kind of run through and just describe a little bit about each type of planning, because that is something that you will be exposed to going forward. Now, for as long as I've been in the discipline of dosimetry, you have seen some changes regarding how planning is done. When I first got into it, you could do uh, actually a digitization of films and create plans based off of that. Nowadays, you would almost never see that kind of thing going on. However, you still have 3D, IMRT, and eventually we'll see some stereotactic examples as we go through. 3D is pretty much it's the most basic type of planning that you will come across nowadays. Here are some examples as you can see them. If you wanted to say do a 4-field prostate, for instance, this happens to be the pinnacle a pinnacle planning system. What you are seeing here is the aperture as it's drawn. It looks like this is an AP field. And so you see your target here and you're giving it a specific margin around, and it looks like this is the block right here. Not quite sure if it's Cerebend or if it's MLCs, but you're seeing the area of exposure around it. Now, this is something that you just simply take and you can draw bit by bit as you go around, or give it a set expansion. And generally, when it comes to 3D planning, you're going to set your beam angles manually. You're going to go in and say, if it's a 4-field, you're going to do an APPA right and left, that kind of thing. And also the fields don't really change. The only exception to that is if somebody puts segments or step and shoot into their plan in order to try to cool certain spots down. And all of this, the 3D planning is pretty much defined by the fact that there is no inverse planning element to it. What I mean by inverse planning is that you're not taking certain parameters and handing it to the computer and say, okay, you figure out how you want the dose distribution handled. And that's not what's going on here. In 3D planning, what we are doing is we are trying to figure out how to get those isodose lines to look the way we want them to look. And we're doing it piece by piece as we're putting together the beam arrangements, as we're putting in the field, the blocks, any wedges, weights, different energies, that kind of thing. That is considered to be forward planning. And the forward planning is something that is done by the dosimetrist or physicist in order to be able to generate the isodose lines that we're looking for. 4 fields are usually pretty easy when it comes to breast plans, brain plans, things of that sort. Again, the parameters are pretty much all the same. You are looking at setting field arrangements, and those field arrangements can be static fields or they can be arcs. Just because something is an arc doesn't make it a VMAT or a volume modulation process. It's what you are looking at in many cases, from a 3D conformal point of view, may be a conformal arc, something that conforms to the target as it moves around. That doesn't mean just because it moves that it's IMRT. So you're seeing some examples here. This is 3D planning. You're seeing the dose volume histogram, which is tallying up how much of a particular structure here is receiving how much dose. It could be normalized, as a percentage, this being 100%, this being 0% as you go through. And then you're seeing the dose here in centigrade as you're going forward. So those are examples of 3D planning. Now, this has really advanced, particularly in the area of head and neck. Obviously, in the head and neck, this is the area in which you have the smallest amount of space and also the highest volume of critical structures that's concentrated in that space. And when you look at it there, I mean, you've got spinal cord, you've got brachial plexus, you've got saliva glands, you've got oral cavity, you've got a mandible, things of that sort. And they're all packed real intense into a small area. Now, as it used to be, 3D planning for head and neck was actually quite simple. And as you look at it today, quite barbaric. You're looking at a monoisocentric setup. In other words, one isocenter for upper beams as well as an S-clav beam down here. You've got a half beam block right here. And on either side up here for either lateral, you may have a little bit of a block over here, but you're trying to expose this particular area here. And then you do the same thing on the other side. And then down here, you've got the S-clav, which is trying to hit certain level of nodes going in here, and then trying to avoid the spinal cord in the back. Now, you may ask yourself, can you do this to 60 gray? If you're exposing the cord, the answer is no. And one way you try to get around that is running this to, say, 3960, and then cutting out the area here that has a cord and hitting this posterior strip, what they would call a posterior strip, with electrons, because the electrons don't penetrate in towards the cord as much as the photons do. So you're trying to spare the spinal cord at that particular point. And you take that up to a particular dose, whatever it is. Now, as you might imagine, you're raking all kinds of havoc through normal structures as you're using this particular technique. So is it any wonder that we've tried to figure out how to be able to do this a little bit better? Well, as computer programs and algorithms have improved over the years, some smart apple came up with the idea of being able to take the multi-leaf collimators and have them move during a certain amount of time during the treatment. And when they move, you can block certain structures and you can expose others. So as you're doing that, guess what? You are being able to save some of the normal structures, particularly spinal cord in this particular case, but expose other areas within the head and neck that are in fact riddled with disease. And not only that, you can also expose them to different dose levels. So there are ways to do this. And some of the ways to do this involve using arcs, which is the volumetric modulation. You can also do that using static beam. So if we were to, let's say, go here, I do want to go over the summary that we have here in Khan regarding this. When it comes to IMRT, basically you're looking for a computer treatment planning system with IMRT software and a beam delivery system capable of non-uniform fluences. In the past, those kinds of things have been done very, very basically with something called the Peacock system, which is something that you could attach to the head of a machine, and in order to be able to have the fluence or have the fluence modulated by having the leaves move to different positions. Now we've gotten to the point where we've got several different machines that could do it several different ways. When it comes to IMRT planning, inverse planning algorithms with plan optimization techniques such as simulated annealing, are best suited for IMRT treatment planning. And we'll see a little bit of an example of that. Basically, what you are looking for is a program that will do inverse planning, where you hand it the parameters and you say, here, you go figure this out. You're smarter than I am. You're supposed to be able to determine exactly what the fluences should be in order to be able to generate the kind of treatment plan that we're looking for. And again, the delivery is accomplished with MLCs, or in the case of tomotherapy, a slice by slice or in a helical fashion analogous to CT scanning. Now, obviously with IMRT, there's a lot of clinical implementation steps that you have to take. You've got to check the beam delivery, you've got to check the plan, you've got to check the machine, make sure you don't have any issues there. And those are the kinds of things that you have to worry about when it comes to an IMRT program. You want to make sure that what you are delivering is, and what the computer system says you're delivering is exactly what the machine is able to deliver within a certain percentage. And those are the kinds of big things that you have to take into consideration. Now, here's an example, as I was telling you about the 3-field head and neck. This is an example of an IMRT plan. Look at all these different doses that you have going on here. Now, what I'm going to do is I'm going to take off some of these so that it's not quite as busy here. And you can see these volumes here as we go through. And you can see as I hover over it that they can kind of light up. And then you can see I don't know why the 70 is not lining up like that. It should. There we go. Okay. So you can see when I click on it, the areas here in the head and neck, generally, you're going to be looking at a maximum here of around 70 gray. And that's for the gross disease and a little bit of expansion there. And the reason that's the dose level at which these things respond a lot. Now, post-op, you may not necessarily be hitting these things quite as hard, maybe 66 gray or something along that line. But if you still have disease there, they're going to try to hit that as hard as you can. Now, there's no way that you can hit this at 70 gray and try to preserve the cord here at 45 if you're just looking at trying to do this with 3D fields. If you had opposed laterals here, there's no way you could do it. But with IMRT, the ability to be able to move those leaves such that you can expose these areas at different angles and not have this exposed to the same amount, it's pretty miraculous when you think about it. And then you have other areas, other nodal chains that you're going to want to expose. Normally around the 70 here, you're going to want to hit some other areas here at a little bit of a lower dose, maybe 59.4, maybe 60 gray. It kind of depends on the doctor and what sort of disease you're looking at. That's what they're schooled with. And then as you go further down into the patient, you may have nodal chains down here that are lower risk. This, of course, being the highest risk, this being the next highest, and then these being lower risk. But as you go further down into the patient, you're going to have certain areas here that you want to hit with a lower dose. And that's why they're hit with 54 gray here as opposed to 70. So this is just one specific case here, and it's got certain elements of the anatomy here that you can look at to try to see what all is involved in here. This really gets fun when it comes to retreatments. If somebody's already received head and neck treatments and you want to go back and do it again, which nobody really does, but if you have to, at the very least, it can give you an idea as to what some of the tolerances are for these certain structures within the head and neck. What is it you want to hit it with, and what do you want to spare these normal structures with? Then there's the stuff that kind of is in between. For billing purposes, you would still, if you're not handing the computer the dose tolerances or the dose objectives and say, here, you figure it out. If you're not doing that, then what you are doing is something that's forward planning. And in many cases, that's sort of where, particularly breast planning, where that's going. You may run into something called irregular surface compensators, where you're going through and you're trying basically to produce as uniform a field out here within the breast as possible without by changing the dose here by doing dose painting. In other words, you want a little bit more dose here, you want a little bit less here, and hopefully at the end you end up with something that is more of a Van Gogh as opposed to a paint by numbers that I would do. So that's one of the more complex forward planning types of plans that can be put together. This is really quite fascinating. If you get a chance to look at how, or if you get a chance to look at this tutorial out here on Dosepedia, or actually go through and watch a dosimetrist put this together, I would encourage you to try to do that because it gives you an idea as far as what's going on. Other areas, particularly when it comes to, say, whole brain, you might be just shooting those, say, with just opposed laterals. It could be with a very basic block, or it could be to the point where you do this kind of thing. Thought they would have more of a diagram here for it, and you would use what they call field and field, where you draw one huge volume, and then let's see if I can at least give you an idea here. Where you might take some of this area here, and if you had MLCs and you saw that maybe you had a hotspot or something like that out here, you might take a little bit of the weight of this entire beam and you might create a segment, or what's called a step and shoot, or something that is something that looks a lot like this, but it's going to have some MLCs going out and covering a particular area. That is something that is called creating segments, or creating a field and field. And when you sum all of those things together and you put it into one field, which hopefully your dosimetrist does, then you are able to cool down some areas that might be a little bit hotter, but that is still considered forward planning and is still considered a 3D approach. So these are the kinds of things that you're going to end up seeing in the clinic. And I hope that this little tutorial over 3D and IMRTs helps you out. The other thing that I would suggest that you learn a little bit about here is called the dose volume histogram. Again, what you were looking at here, generally the normalization volume here is going to be in percentages, 100%, 90%, 80%, 70%. Your volumes are going to be listed here, and you're going to see a graph of them as they go across here. And you will see exactly what percentage is receiving a particular dose. And they're color coded so that you can see that, say, here 50% of the structure is receiving, somewhere around 4 to 5 gray. Here 50% is receiving a little bit more than that, and so on and so forth. What you are generally looking for in a dose volume histogram is for your target to be out and then come straight down with very, very little shoulder, or the bend here in the target. That's what you're looking for. And you're also looking for the normal structures. You would love for them to all be over clustered on this side. Generally, that doesn't happen. Generally, they kind of cascade down through this middle section right here. But you would love to be able to have all of your normal structures that you're concerned about getting as low a dose here as possible. So those are some basic things about 3D and IMRT planning that I hope you can take to heart.